Hello, Dr. Todorova. This is Bryan Haas here again. Last video. This is Rebecca. Rebecca did give us permission to go ahead and videotape this musculoskeletal exam and upload it to YouTube.
Yes.
Awesome. I'll start off the exam by, don't worry, it's gonna be too private. Don't worry. It's only for the school to start off the exam by washing my hands. I enter the room. This is a musculoskeletal exam. First, I want to start off by inspecting. I want to inspect the fingers there. We're looking at see if there's any redness, any swelling, any nodules, any deformities, any asymmetry in the joints itself, in the proximal, distal, and the metacarpal phalangeal joints there. Those look good there. And then we want to see and palpate the actual joints itself. We want to palpate the distal, the proximal, and the metacarpal phalangeal joints there, palpating for any pain or tenderness there. The next is we want to check for range of motion. We want to see if the patient can go ahead and make a fist. That's good there. And then we want to see if the patient can then ulnar and lateral deviate the hands there. Go ahead and make a fist, extend and flex the fingers there. That's good. And then the next part of the exam is going to the wrist there. We're evaluating and inspecting the wrist for same thing, any redness, swelling, any nodules on the radial side, the ulnar side. And then we want to palpate those areas as well. We're palpating the wrist on the inside of the ulna, the radius on both sides there. And we also want to palpate the metacarpals in the hands there, and also the little carpal bones of their wrist. We want to see if there's any pain or tenderness on the anterior and posterior sides of the wrist there. We did ulnar and lateral deviation of the wrist. We want to do also flexion of the wrist there, extension of the wrist there. That looks good there. So we do flexion, extension of the wrist there. A couple tests we can do of the wrist is we can do Tinel sign. So if we have the patient extend the wrist, take our middle finger there, we tap the median nerve there in the carpal tunnel. If that elicits pain, numbness, tingling, some pain, it can be the index finger, the middle finger, and the lateral part of the ring finger. That's a positive sign for Tinels. We do the opposite for extend. We do tap that there. That's Tinel sign. You see if there's any numbness, tingling, or any pain at all, radiating pain into those fingers there. Then we do phalans. Phalans we can do bilaterally like this. Have the patient hold that for a good 40 seconds to a minute or so. If that elicits numbness, tingling, pain in the index, middle, or lateral part of the half of the ring finger, that's a positive sign for carpal tunnel as well. Then we go to the elbows. We're looking at the elbows there. We're inspecting the elbows to see if there's any redness, any swelling. We're looking at symmetry, any deformities. We want to palpate the elbows. We're going to palpate the olecranons in the back. There's olecranon fossa in the back there. Palpate the medial epicondyles, the lateral epicondyles of the wrist. To see if there's any pain or tenderness. If there's pain on the medial side there, that could indicate a tendonitis, and that's a golfer's elbow on the medial side. On the lateral side, if there's pain and tenderness along the epicondyles there, along the tendons where they attach, that could be a tennis elbow there. And as we're palpating that, we're just palpating the whole elbow itself there. And then we'll have the patient go ahead and flex the elbows there, extend the elbows there. Good. Let's see you then supinate, which you're going to bring your hands like that, and then pronate. Sorry, this is pronate. Yes, this is supinate. We're seeing if there's what the range of motion is like in pronation, supination, flexion of the elbows, extension of the elbows. Those look really good there. Next, we're going to move up to the shoulders. We're looking, same thing with the shoulders. We're looking, we want to see if there's any redness, swelling, any nodules. Some patients that have injuries to the shoulders, their muscles start to atrophy. You want to definitely pay attention to atrophy at the elbows and the shoulders there to see if there's any atrophy of the muscle groups there, particularly the deltoids. So we want to look and inspect not just the anterior, but the lateral and posterior delts, and to evaluate that. And then we want to look and we want to actually palpate those areas there. We want to palpate the AC joint, which is the acromioclavicular joint up here, right where the clavicle meets the acromion process of the scapula there. See if there's any pain or tenderness there. We drop down, and just as we drop down there, right in this fossa here, in this bicipital groove, is the biceps tendon. We want to see if there's any tenderness in the biceps tendon. And then the coracoid process there, we want to palpate the coracoid process if there's any pain or tenderness there. On the back here, the humerus, this is the tubercle of the humerus towards the back, and just above that, there's the bursa there. There's the posterior deltoid humerus there, super deltoid bursa there in the back there. See if that's pain, any painful or any tenderness there. While we're here, we can also check the sternal clavicular joint here and see if there's any pain or tenderness there. And then we want to check a range of motion to the shoulder. Let's have the patient go all the way up as high as you can, 180 degrees, both of them. Okay, good. Good. And then if we go back into extension, it should be about 60 degrees. Go back and extension, back and extension. That looks good there. Okay, then we'll have the patient abduct the arms there. That should be 9 degrees there. And then if we come across, we adduct there, one side that should be coming across, adduction of the shoulder should be about 9 degrees. Adduction of the shoulder there should be about 90 degrees there as well. And then we can do external rotation. Let's see, have you put your arms behind your neck there, all the way down here. There's external rotation of the shoulder. And then if we have the patient put her arms behind her back there, in the small of her back, that's now internally rotating the shoulder there. Then we want to do a specialty test. We want to do it, what's called the empty the cup test. So what we're going to do is bring the arms here, point your thumb straight down, and against resistance, we're checking the supraspinatus tendon primarily. See if there's any possible tear. So against resistance, hold strong there. If any of those arms look weak and or if it was painful in the front where it attaches in the back, that could indicate the supraspinatus tear, I mean, maybe even a partial tear there. Okay, that's good there. The next part of the test there, or the evaluation, is looking at the head and neck. We're looking for symmetry. We're looking to see, if we look at the side, we can look at the cervical spine and the head to see if they have what's called forward head syndrome, where the head's junted forward there. I see that a lot in patients there. And as we're looking there, we can assess the Tmj joint. We have the patient, we're going to palpate the anterior tragus there, where the TMJ sits. Go ahead and open up and close. Open up, close. Rebecca has some clicking and popping. She wears a night guard. She gets some pain in their TM joint on the right side. There's clicking and popping there. And they want to see if they have full range of motion of the TMJ joint. We'll go ahead and open up your jaw and see if you can put 3 fingers there. She has full range of motion, but she does get clicking and popping there. There's some tenderness when I palpate that right TMJ joint there. And then we come here. We want to palpate the cervical spine there. We can palpate the cervical spine, the paraspinal muscles in the back there. We're palpating the traps. She's got very tight traps on both sides there. And in the back there, you got the rhomboids in the back there that line the medial part of the scapula there. See if there's any tenderness in the rhomboids there. That looks good there. Then we want to do Sperling's test of the neck there. We can do Sperling's test. Why we're here is if we laterally flex the head here and we push and we compress the spine there. As we compress the spine, that's compressing the nerve roots of the cervical spine. That can elicit numbness, tingling, pain down that arm there. If there's a lesion in the nerve root, a disc problem, a disc bulge, a disc protrusion, etc. And we, of course, want to check range of motion. So let's have you go into flexion there. That should be about 9 degrees. Extension, 70 degrees there. We do right and lateral rotation should be about 9 degrees. Good. And then lateral flexion should be about 45 degrees on both sides there. Excellent. Okay, next thing is going to have you lay on your back there. We're going to check the lower extremities there. And let's look at the feet there. We're looking at the feet to see, we're looking at the toes to see if there's any redness, swelling, any deformities, any calluses, any bunions, I'll look and see if there's any bunions there. We don't see anything there. Those look good. Hammer toes. A lot of people have hammer toes. I'll make sure there's no hammer toes going on there. And then palpation. We want to palpate the distal and the proximal phalanges there, and the metatarsal phalangeal joint there too, to see if there's any pain, tenderness in the toes there. And then we can have the patient do flexion of the toes. Let's see you flex your toes there. Extend back in your toes. That's good there. Okay, relax there. Then we can have the patient will invert and evert the feet there to see how the range of motion is there, and that's really good. And then the back, as we look underneath there, we inspect and look under and see if there's anything going on with the plantar fascia. If we palpate the plantar fascia, we can see if there's any plantar fasciitis, any Morton's neuroma there. Those are really common there in the bottom of the feet there. Even the Achilles there, or the heels. If we palpate the heels there can be pain back there. Morton's neuroma, any plantar fascia there. Good. And then if there's some plantar fasciitis issues, a lot of times their patient has pronation of the feet. Go ahead and stand up and let's see if their feet pronate, or pes planus, where there's flat feet there. As she stands, you can see how both arches collapse there. Not 100%, they're not completely flat, but I should be able to stick my finger underneath the arch there, and I can't do that. This left one's worse than the right there. That means both of her arches are collapsing, not 100%. I've already recommended that she wears orthotics or some arch supports to help support her plantar fascia and the arches there. The next part of the exam there, I was looking at the ankles there. We're looking at the ankles, and we want to check and see, we're looking at, again, any redness, swelling, any decubitus ulcers, anything abnormal there. Palpate the medial and lateral malleolus there, Achilles tendon for any pain, palpation, or pain or tenderness there. Then we'll have the patient do a passive range of motion. So let's see, do extension of your feet, flexion of, sorry, passive is me, sorry. Let me do extension and flexion of your feet, and then we'll do clockwise rotation, circular motions of the feet, counterclockwise, circular motions of the feet. That's passive range of motion. Then let's see you do those same movements there, flexion and then rotations. Good, and that's active. That's good range of motion there. Excellent. Next part of the exam is the knees. Let's look and see if there's any redness, swelling, tenderness of the knees, any deformities. A lot of people have where the knees have a valgus or varus deformity. A valgus deformity is where the knees are knocked and this lower part of the leg, it comes out like that. The lower part of the leg comes out like that. It's very common. And bow leg would be the opposite, where this in part of the knee bows in like that. Her knees look straight there. No deformities there. The next part is palpating. Want to palpate the knees itself, the patella. There's a lot of people have problems with the patella. And the patellar fat pad underneath, we can do the super patellar knots there. There's a little notch there as well. We can palpate medial and lateral sides of the patella, kind of move the patella back and forth, up and down. With hers, she's got a patellar issue. There's some clicking and grinding, some crepitus when I do that into her right knee there. She has also a meniscus problem in her knee, so I'll be careful when I do the meniscus test. As we palpate there, we can palpate the medial and lateral femoral heads there to see if there's any pain there where the meniscus are. We can palpate the popliteal fossa for any Baker cysts in the back. That looks good there. And then we want to do some range of motion tests of the knee. Let's see, go ahead and bend your, so if it's straight like that, that's 0 degrees. She has full extension, which is normal there, so it's good. Then go ahead and bend it as much as you can. Let me do it first. So let's do passive. So passive there, good. Now you go ahead and do it. Active, 120 degrees, passive, good. You go ahead and bend it, good. A nice flexion of the knee there, good. And if we do some specialty tests, we want to do Valgus and Varus. So if we do the Valgus test, I'm going to press here, take the inside of the ankle here, the medial malleolus there, and I'm going to push out like this. We're testing this Valgus test is stressing the medial collateral ligament on the inside of the knee. If there's a medial collateral ligament strain, or sprain I should say, if it's sprained, there will be pain, tenderness, and there'll be laxity of that medial collateral ligament doing the Valgus test here. So we do the Valgus test here, bend the knee. It should be, the knee should be bent about 20 degrees or so when we do that. It shouldn't be straight. That's the Valgus test, and testing the medial collateral. The Varus test is the opposite there. With the Varus test, we're going to grab inside here and then push inside there, slightly bent 20 degrees there. That Varus test is testing the lateral collateral ligament on the outside of the knee there. Same here, bend slightly there. We're going to bend that. Good. So that's testing negative there on the lateral collateral ligament there. And then we have the Lachman's test. Lachman's test is you bend the knee slightly here. We're going to stabilize the femur here. We're going to just above the tibial tuberosity, we're going to do an anterior and posterior movement or pressure to see and test the ACL and PCL ligaments there to see if there's any laxity. If there's any laxity, you'll get about 3 millimeter degree movement or in the anterior and posterior side if we're testing the ACL and PCL there. So we're going to stabilize that and see in the Lachman's test there if there's any significant movement of the ACL or PCL. Her ligaments are stable there. And then we can do the anterior and posterior drawer test. We're going to sit on our foot there. We're going to grab just behind the knee, stabilize our knees just below the patella there, around the tibial tuberosity. And then we're going to pull forward anterior and push backward, anterior and posterior drawer test, testing the ACL and PCL ligaments again. Sit on the foot there, and we pull forward, push backward, ACL ligament test there. Like we mentioned before, we want to test the medial and lateral meniscus there. So this medial meniscus here, when we test that, if we test the medial meniscus, this is Mcmurray's test. So if we do this here, we're going to internally rotate the lower leg there, and we're in flexion, internally rotate, and in extension there, as we go into extension, that will elicit pain if there's a problem in the posterior lateral part of the meniscus on the outside there. That's testing the posterior lateral meniscus there. If we turn the foot and externally rotate the leg and come into extension, that tests the posterior medial side of the meniscus there. So this is Mcmurray's test testing the meniscus there. I was real gentle with her because she has a meniscus problem in that knee. Same with this one here. We're going to bend it, slightly turn it inside there, and with flexion, and we come into extension, it's testing the posterior lateral part of meniscus. If we turn it out and go from flexion to extension, it's testing the posterior medial part of meniscus on that side there. Great. All right, so next part of the exam is we're looking at the hips there. So if we look at the hips, we're looking for, okay? We're looking at same thing, redness, swelling, any deformities there of the hips. We want to palpate the ASIS, see if there's any tenderness in the ASIS, in the greater trochanters there, any tenderness there. And then we'll ask the patient to go ahead and turn on your stomach there. And we want to palpate the posterior superior iliac spine, the PSIS there, no tenderness there. And we also want to palpate the SI joint is right there, see if there's any pain or tenderness in the SI joint. Next is we're going to do some range of motion tests. We're going to have, I'm going to do extension of the hip. I stabilize the sacrum when I do range of motion of the hip there. I stabilize the sacrum there, and I'm going to extend the hip there, see if there's any tightness, any pain, any swelling. So this is the active part there. As we do that, good. And then we'll have the patient do that, and we'll do passive, passive, good. And then the other one, good, good. Okay, and then we go on your back again. Yeah, yes.
You said you were active.
Oh, so we'll have the patient bring their knee towards their chest there. That's active, range of motion, and then I'll do it, and that's passive. Let me do it. So there's passive as I do it there. Good. Do the opposite one. That's just flexion of the hip there on both sides, left and right. and then passive is me flexing the hip there. Good. And then we want to do external interrotation of the hip. So I'm going to do active first. I'll actually do passive first. So I'm going to flex the leg here about 9 degrees. And then what I'm going to do is I'm going to turn the lower leg in to externally rotate the hip to see what the range of motion is like there. And then as I bring the leg out, now we're doing testing internal rotation of the hip. So you go ahead and try that yourself. So there's external rotation of the hip, internal rotation of the hip. And we do the opposite here. So bend this here. As we turn this in, we're testing the external rotation of the hip, internal rotation of the hip, and you do both there. So there's passive, and now she's doing active internal rotation. The next is abduction and adduction of the hip. So I like to stabilize the ASIS on one side as we abduct the hip. I'm going to do active first. If we abduct the hip there, that should be about 60 degrees as we abduct the hip. Good. I will stabilize the ASIS, and then we'll have the patient go ahead and do that 60 degrees there. And let's do the opposite here. So we're testing this here, abduction of the hip. Good. We'll stabilize the opposite ASIS and then do the same again. Good. Okay, next is adduction of the hip. So go ahead and we'll test this for adduction. We're going to stabilize this hip. We're going to test adduction of the right leg, the right hip. So we're going to bring the leg into adduction. That should be about 30 degrees. That's active, and passive, sorry, and then you go into passive there. Good. Active. Active, passive, active, passive. All right, do this one here. And then I'm going to do passive here and bring that over, adduction of the hip, and then you go ahead and do that over there. And that's active. Very good. Okay. And then we already did flexion there, so that was good. All right, then we want to do Thomas test. This is a hip flexor contraction test. So what we'll do is have the patient grab their leg and just kind of bring it towards their chest. This is testing the right iliopsoas, which is the hip flexor on the right side. This leg should remain straight. If it's bent or the hip comes up, that means there's tightness on this. This flattens the lumbar curve. That means there's tightness or contraction of the hip flexor on the opposite side. Hers remains flat. Do the opposite. Do this one here. This should remain flat, and it does. Flattens the lumbar curve. If that was contracted, that iliopsoas was contracted, that would come up there. That would flex in. And then we want to do Patrick Verbeer's, which is flexion, abduction, external rotation of the hip. Have the patient do that. We stabilize the ASIS. We push down on the femur here, on the thigh, and if there's, we're testing to see if there's any clicking, popping in the hip joint, the hip socket itself, or in the SI joint. Is there any pain or tenderness or swelling in the SI joint there? And we do the opposite there. Come down. Good. Push down there. Good. And that's Patrick Verbeer's there. Good. You know, while we're here, I'm just going to do the straight leg raise. So we do the straight leg raise test. As we come up here, this is testing to see if there's any disc bulge, disc protrusion, any compression on the nerve root exiting the spinal cord. So as I do the straight leg raise, we're stabilizing the leg and the knee here between 45 and about 70 degrees or so. If that elicits numbness, tingling, shooting pain down the leg, that's a positive sign for sciatica or a disc problem or spinal cord lesion. Past 70 degrees into 90 degrees, if there's pain, it'd be in the lumbar spine or the sacroiliac problem on that side. So that's kind of ruling out those two. And we do a straight leg raise here on this side as we come up there. Good. That's negative on that side there as well. Okay, great. Let's have the patient stand. Stand right here. All right, turn and face this way. Now we're assessing the spine. We're checking the, if I look on the side view, we're seeing the cervical curve, we're seeing the thoracic curve, the lordosis there, what kind of lordosis they have, do they have a sway back there? And when we check from behind, we're checking to see if the shoulders are symmetrical, if one's higher, one's lower, the hips, if one's higher, one's lower. We can look and see if the crease, the buttock crease there, if that's lined up in the center there, and the gluteal fold is even and symmetrical on both sides there. We're going to have the patient go into flexion there, all the way into flexion. As the patient does that, I run my hands down the spinous process. I can feel if there's scoliosis there. We're looking as the patient's bending forward. I can see the shoulder height. We can see if the hips are symmetrical and even there and come all the way up. And we're seeing there's a nice fluid flexion movement there. Any pain, discomfort, actually go down again. Someone who's got scoliosis, one of the first things I noticed there is you can see rib humps on either side. There's an asymmetry of the ribs there, causing that rib hump with an S curve or a double S curve scoliosis. How the patient going, that should be 90 degrees there. Extension should be about 35 degrees. That's good there. And we're gonna, you know, there's taught to percuss the spine with the ulnar ulnar prominence of our hand there. I actually like to palpate and percuss with my fingertips there. I can percuss and have a good feel for the percussion of the spine as I palpate that, and the interspinal ligaments too. I can palpate the interspinal ligaments to see if there's any pain, tenderness, or swelling there as we do the exam there. Okay, that's good. So we'll have as the patient's there, we can go into extension. That should be about 35 degrees there. Lateral flexion, left and right lateral flexion should be about 35 degrees. And then rotation to both sides should be about 30 degrees there. Okay, have a seat. No, have a seat. I did straight leg raise. Dr. Todorova, that concludes the exam, the musculoskeletal assessment. Thank you so much.